Okay, welcome back, everybody. If I could have your attention, we're going to get our event underway. So once again, my name is Stephanie Gadbois, and on behalf of the Economic Club of Canada, it is my pleasure to welcome you to our event. Before we begin, we are reminded and we respectfully acknowledge that we are on the traditional territory and home of Indigenous people. The Wendat, the Anishinaabe, the Haudenosaunee, the Chippewas, and the Mississaugas of the Credit First Nation, land steeped in a really rich history dating back many generations. The purpose of our acknowledgement today is to show our gratitude and our respect for their contributions and to recognize the role of treaty making in what is now Toronto. For those of you who aren't familiar with the Economic Club, we stand as this country's national podium of record, and we are a nonpartisan national public policy platform that unites leaders, innovators, and experts from different industries to discuss and address key issues shaping the future of our country. Our foundation is firmly Canadian, yet our influence spans well beyond our borders. Our commitment to fostering collaboration, promoting thoughtful debate, and encouraging action continues to drive all of the work that we do. The Economic Club is more than just an event podium. It's a platform for transformative ideas, helping to guide Canada towards a brighter and a more prosperous future. Over the past year, the Economic Club has partnered with Manulife to bring you a series of women's health events. And so we are thrilled to be presenting our third in our series today, where we'll be shining light on all issues that have to do with endometriosis and women's gynecological health. So today's conversation is especially timely since March is Endometriosis Awareness Month, and we felt it was the perfect moment to bring forward this conversation. Endometriosis affects 1 in 10 Canadian women, yet despite how common it is, many women still face years of symptoms before receiving a diagnosis, limited treatment options, and a lack of understanding of what endometriosis can be for your day-to-day life. And I know this because I am one of those women. My journey began when I was 21 years old, and I was diagnosed with stage 4 endometriosis. I was fortunate in a lot of ways, though. My diagnosis came quite quickly compared to so many others who have to fight for years to get a diagnosis. But even with an early diagnosis, the path for me was rarely simple. I spent 15 years placed in medical menopause on a huge cocktail of HRT, and my body certainly paid the price. And for me, that journey ended at 44 years old with a full hysterectomy. So sharing experiences like this one is not always easy, but conversations like today's matter because they help raise awareness, advance research, and push forward policy, medical, and societal changes that women so desperately deserve. So today, our discussion is going to explore the barriers many women face receiving timely diagnosis, highlight the latest in research, and examine the critical role that education and advocacy can play in improving women's health care. Whether you're a healthcare professional, a patient, or an advocate today, I hope that today's event provides a space for meaningful conversation and practical insights, and help advance both the dialogue and quality of care that women so desperately need to receive. And with that, Manulife has sent along a video that we'd like to share before we get things going. So please turn your attention to the screens.
It's very overwhelming to figure out how to navigate this stuff. Maven really changed the way I see myself and the care that I deserve.
I was on this roller coaster ride. I felt like I couldn't get out of it. I talked to the mental health provider, and she made me look at things in a different perspective.
Maven helped me become more empathetic, more caring, more resourceful and supportive for Erica.
I turned to Maven because I needed help, and that was really, really helpful in my recovery, to just be able to talk to someone.
Maven was our foundation for learning what parenthood was all about.
Maven was a game changer for me.
And with that, I would like to welcome Nicole Wellbanks, Head of Group Benefits Marketing at Manulife, to get our event underway. Let's give Nicole a warm welcome.
Thank you so much, Stephanie, and thank you for sharing a bit of your story with us. Like Stephanie said, my name is Nicole Wellbanks, and I'm Head of Marketing for the Group Benefits business at Manulife, a business that serves over 27,000 Canadian companies and about 1 in 3 Canadian households. Thank you all for being here today for this important conversation on women's reproductive health. And thank you to the Economic Club of Canada for continuing to provide such a meaningful forum for these important discussions. I hope all of you enjoyed lunch and had a chance to connect with some of the incredible people we have here with us today. It's my pleasure to welcome you to the formal portion of today's event. I'm very honored to represent Manulife and proud to share that we have been the title sponsor of this 4-part series focused on advancing women's health in Canada. As Stephanie said, today marks the 3rd event in the series, and we are thrilled to be playing a small role in bringing these vital conversations forward. At Manulife, we believe that investing in women's health is essential to building a healthier and more inclusive future. And just as importantly, normalizing conversations like the one we're having today is a critical step in breaking down stigma and closing long-standing gaps in care. Our goal in supporting this series is simple: to help remove barriers that prevent women from being heard, believed, diagnosed, and supported, whether that's in our healthcare system, our workplaces, or our communities. When it comes to women's reproductive health, the evidence shows that we still have lots of work to do. Infertility impacts about 1 in 6 Canadian couples, a number that's doubled in the last 40 years. And according to Manulife claims data, under 10% of Canadians have coverage for fertility treatments. Endometriosis alone affects approximately 10% of women of reproductive age, and in Canada, nearly 2 million people are living with the condition. Diagnosis is often delayed, and during that time, many experience chronic pain, fertility challenges, mental health impacts, and disruptions to work and daily life. These delays reflect broader challenges: gaps in education, stigma around pelvic pain, and limited access to specialized care. This afternoon, we'll hear from a panel of experts and advocates who are deeply engaged in advancing women's reproductive health in Canada. Their insights will help us better understand the challenges women face and the opportunities we have to improve access, equity, and outcomes. Please join me in welcoming to the stage Zahra Jivan, Dr. Jamie Kroft, Dr. Cindy Maxwell, and Julie Anderson.
Okay, hello everyone. We have about 40 minutes, which is definitely not going to be enough time to get through all of what we need to talk about for this discussion today, but let's see how far we can get. So on the panel today, we have Julie Anderson, a Senior Director of Clinical Outcomes at Maven Clinic, where she focuses on improving access, navigation, and outcomes across women and family health. We have Dr. Jamie Kroft, an obstetrics and gynecology surgeon at Sunnybrook Health Sciences Centre, Deputy Chief of the Dan Women and Babies Program, the robotic surgical lead at Sunnybrook, and the past president of CanSAGE, the Canadian Society for the Advancement of Gynecologic Excellence. She specializes in low-risk obstetrics and minimally invasive gynecological surgery with the focus on endometriosis and fibroids. And then at the end, we have Dr. Cindy Maxwell, Vice President of Medical Affairs and System Transformation at Women's College Hospital, with the focus on reproductive and pregnancy care, women's health equity, and system-level access. So a great panel to talk about women's reproductive. So the first question I want to ask the panel is, just given where each of you sit within women's health and within the system, when you look at the current state of women's reproductive health in Canada, what issues feel the most urgent to you and why? Start with you.
Yeah, I'm happy to start us off. And thank you to the club and to Manulife for having us here today. It's an exciting event. And maybe I'll start by just giving folks, I know we had a lovely video about Maven here with some dramatic music, but I'll give you just 20 seconds on what it is so you understand the framework with which I'm speaking about some of the issues that we see in our business. But Maven is a wraparound care management and virtual care platform. So we partner, sort of sit around in-person medical care. So maternity journeys, people go to their obstetric and gynecology practice. Fertility, they go to their clinic or their reproductive endocrinologist, et cetera. And we really sit around that and give people access to care 24/7, obstetric providers and ancillary providers like mental health. And we help with what I would say is probably one of the biggest issues that we see, especially in the Canadian population, which is access. Really, wait times for some of those ancillary providers in particular. And as everyone on the panel knows, reproductive health is really a space where outcomes and risk change rapidly. And so if you get a new diagnosis, or something is happening in your reproductive or regular life, and you have a mental health issue that arises because of that, or you have an injury where you need a nutritionist or a physical therapist, for example, to help you with recovery. All of those things can lead to really long wait times, which can lead to people dropping out of the workforce or needing to take time off. And there can kind of be this, negative cycle associated with that, where they're not getting the right care, and therefore, things get worse with their mental and then their physical health, et cetera. So that's one of the real things that we see on the platform is folks using a platform like Maven to access care that they're going to need to wait a long time for, and to access care that they need that sort of specialized view of an ancillary provider. So a mental health provider who knows what they're going through, because all they do is help people on fertility journeys, for example. So I'll stop there and pass it along.
Thanks. I also feel like I could speak for the entire 40 minutes on what the challenges are in women's healthcare in Canada right now. As somebody who subspecializes in treating patients with endometriosis and fibroids, I echo what Julie is saying, that I think the biggest challenge is access to care for our patients. So as a specialist, unfortunately, my wait times are 12 to 24 months for patients to come and see me, and I say if I could replicate myself and work every day, I would, but there's only one of me. And unfortunately, right now, I can't even accept new consults because I feel that it's unfair to keep patients waiting more than 2 years for a consultation with me. And then access to surgical care is then the second hurdle. So patients can wait 12 to 24 months to see me and then sit on a wait list for surgery for another 12 to 24 months for access to specialized care. So I think one of the biggest things that we need to address is access. I think the other pillar that we need to focus on is education. So there is only one of me. There's only so many specialists in certain specialized areas, but the more we can educate providers as well as patients, the better off the patients will be as well throughout the country.
I have to agree with everything that's been said so far. I'm going to wear my clinician's hat for a second and then maybe talk a bit more broadly about the system. So in my clinical practice, I am a high-risk obstetrician, or what we call a maternal fetal medicine specialist, and I provide care for people who have chronic conditions, sometimes acute conditions, but typically chronic health conditions in pregnancy. So things like inflammatory conditions, cancer, and in some cases obesity, people living with obesity. And so generally speaking, if you need urgent care in an obstetrical setting, you can usually get that care quite quickly. So the immediate access is maybe not so much of an issue in my practice. However, when individuals are accessing care and are feeling uncomfortable talking about their symptoms,
or are having difficulty affording, let's say, to travel to a clinic or to a hospital to obtain that care. There's all different ways that access impacts patients and families. So that I think is worth thinking about. Cultural safety as well. So depending on where you're from or where your ancestors are from, you may have a different worldview or experience when you access healthcare, and may not be comfortable sharing your symptoms, or you may have experiences where, for example, if you're a racialized person, you may feel unheard. So you may share those symptoms with the clinician and not feel like the seriousness of the symptoms are being fully appreciated. From a systems lens, I thought it was great in that video that the McKinsey report on the women's health gap was referenced. And if you haven't read it, I would encourage everybody to read it. It's really interesting. There are data in there talking about the loss to our gross domestic product, our GDP in Canada, as a result of the women's health gap. So maybe my comment would really be about that gap. So what is the women's health gap? And it's really our lack of focus on the influence of sex and gender as it impacts healthcare, the quality of healthcare delivery. And in that report, you can read all about the different areas that are impacted by this gap, the efficacy of care. So, for example, so many women don't get screening for a number of health conditions, things like cervical cancer, for example, but we don't really have screening for endometriosis either, and we know that it probably affects many more women than actually come forward in the clinical setting. So screening is an important issue. The quality of the care, we talked a little bit already about access, so that's an aspect of it as well, but so is the diagnosis and the treatment, the access to the treatments that are required. And then the data gap, that's a big one. So traditionally, as I'm sure many of you know, most medical research into most conditions was focused not on women, but on men. And now we are, shifting to focus on having research, data, and knowledge translation and mobilization that does need to be disaggregated by sex and gender. So we need specific information about healthcare outcomes and the effective treatments as they affect women and gender diverse people. So I think we'll talk about some solutions later on in the conversation, but those are my thoughts at the moment.
Yeah, thank you all for sharing. It's every time I get into a conversation about women's health, it just feels overwhelming because there's so many different parts that need to be looked at, uncovered, changed. And I would just love to hear from where each of you are at. Maybe I'll start with you, Dr. Kroft. Where do you see momentum? I think we could spend, probably the whole day talking about all the challenges. And I think one of the really great things that could come out of this conversation is, how do we move forward? What do we need to do? So if you can talk about where you're seeing momentum, but also with that momentum, like what needs to continue to change?
Thanks. Yeah, I think that, when I was a medical student, the first time I heard about endometriosis was at a second year lecture that I listened to. I had never heard about the condition before. I think that, it's really nice that there's more people talking about conditions like endometriosis and fibroids, more patient education. So it's bringing these topics forward. One project that I'm currently involved in as past president of CanSage is we were fortunate enough to receive funding from Health Canada in the amount of almost $500,000 through the Sexual Reproductive Health Fund to educate primary care providers, emergency medicine physicians, as well as general gynecologists about endometriosis. And so that's a 2-year project. So the dedication that is, being put forth by government to spend money on education to provide better care to our patients in Canada is really inspiring to me. So that type of funding, and also emphasis placed, within our sort of regions, definitely at our healthcare institution, women's health is becoming more of a priority. So I think that as well, it comes from the general public, and we are in a universal healthcare system. It's strapped. There's only so much funding that is available, but we've had a lot of interest and engagement also from the public and from donors, from industry support, and that's really vital at being able to provide the most cutting-edge treatments to our patients and across Ontario and the country. So that's inspiring, as well as emphasis on research within women's health as well. I think a lot of the funding has traditionally been in cancer and other conditions, and the conditions that I see and treat are called quote unquote benign gynecology. And I really don't love the word benign gynecology, because we know that it has so much impact both to quality of life, as has been mentioned here, in terms of workforce productivity, but also there's actually a lot of physical, real symptoms that these conditions can cause. They can impact the lungs, the kidneys, cause iron deficiency, anemia, very significant physical impairment to our patients. And so I think that emphasis on swaying away from referring to these as quote unquote benign conditions, and really putting more emphasis on research into these areas is inspiring to me.
Dr. Maxwell?
I agree with all of the things that Dr. Kroft has mentioned. I would say, so I'm an optimistic person, and I do think that positive and meaningful change will come to women's health and to the health of gender diverse people. And there are some really good signs on the horizon, I would say. Most recently, I think just last week, our federal Minister of Health made an announcement for funding to be directed to a number of women and women's health, reproductive health, gender diverse health projects. So there was one on endometriosis, I believe. There was one on abortion care. There was one for the Canadian Association of Midwives, who provide not only pregnancy care, but quite significant amounts of supportive women's care in our health system. There was also an award to the Society of Obstetricians and Gynecologists of Canada, which is our national professional society. And that grant was focused on supporting menopause care and education to build capacity amongst caregivers and health practitioners across the country. So I think when we see a national announcement focused specifically on women's health and to target those particular areas, I think that is meaningful. A few years ago, 2 years ago, there was an announcement on universal access to contraception, which I think is a game changer, very important for access, both to medical and device-based contraceptive methods. In terms of research, very recently there was established a pan-Canadian Women's Health Coalition by our federal granting agency, the Canadian Institutes for Health Research. And so these grants were to establish hubs on women's health. Hub grants are a little bit different than project grants, because typically a hub is like a network, so it will have multiple research teams from all the provinces and territories participate in a national effort to address certain health conditions. So all 10 of those hub grants are focused on different areas in women's health, but also geographically. There's a couple that I'm involved with. One of them is called Justice and Equity in Perinatal Healthcare, and another one has to do with knowledge mobilization around severe maternal morbidity, mortality, so complications in childbirth. So I think that those are a few very encouraging signs. Just one other thing, regionally in our province, we have all heard about the efforts of Dr. Philpott and the Primary Care Action Task Force to ensure that Ontarians, 300,000 or so Ontarians, will have attachment to primary care. And that is an incredibly important aspect of ensuring that women and gender diverse people have access to basic screening, assessment for chronic conditions, for gynecologic conditions as well, an important portal for people to access care.
Yeah, it's great to see and hear about all the different initiatives that are going on. Maybe Jill, ask you a different question. So, as we hear about, some of the different projects and the different momentum around women's health, as we look ahead, what would you say needs to be true in order to really see meaningful change in Canada for women's reproductive health?
Yeah, that's a great question. I come back to access, and I think awareness and momentum are real things where progress has been made. But I think what Maven is part of is sort of this idea of, let's take the resources that we have and let's be more judicious with them. Let's put them in the right place at the right time. And as Cindy said, it's not just about access, and what the number is of your wait time. It's about access to the right care that's actually going to get you to engage in the right way and get you to the right outcomes. So I think that's one piece that virtual health in general has done a really good job at, but there are lots of initiatives that I've seen where I think we can do more, but the idea of how do we get the right provider to the right person at the right time? That can be virtual, that can be supplementary models, but there's been a lot of progress there. I think the place that both in the US and Canada that is remains to be a real challenge is that supply of providers, and how do we actually train the people that we need and get them to practice in areas that may be more remote. We have a real problem, especially in the US, with care deserts, obstetric care deserts. It's a huge problem in Canada as well. And we work with a lot of employers where that's, they're a big chunk of their workforce are in those areas that have lower access to care. And they turn to a service like Maven to try to do that idea of let's plug the gap for these people. But as our chief medical officer likes to say, you can't deliver a baby through a screen, except when you really, really have to. But that's a whole different ball of wax. But that at the end of the day, if a county or a province or some area doesn't have an obstetric provider, or doesn't have the right facilities to provide people with the trained care that they need to treat their endometriosis or to help them with their fertility journey, that's just not something that a digital solution can change at the end of the day. So I think that's another big part of how do we develop the right provider pipeline and the right incentives to get people the care that they need in 5 or 10 years.
Yeah, I completely agree with that. I think we have to start thinking outside the box at solutions that aren't necessarily what we've been doing traditionally, so that we can improve access to care. So at Sunnybrook, we've started what's called the C Clinic, the Sunnybrook Expedited Endometriosis Clinic, so that we can offer patients an expedited way to evaluate if they have endometriosis and get earlier access to treatment through a virtual clinic run by nurses and physician assistants overseen by endometriosis experts, because again, there's only so many specialists, but this is a way that we can expand care through a broader region and have more patients be able to access this care by offering it virtually and through allied health. So coming up with these types of different solutions to the problem of access to care, to centralized referral practice, so that people that have openings for care can direct patients to those providers, whereas certain more specialist providers can take on the more challenging cases, for example, surgically, so that we can better provide the care where it needs to be provided. And I agree that there's many places that don't have access, that are rural or other smaller areas, and that's a huge challenge, and it really puts the onus on the patient to advocate for themselves and their care, and I see that a lot. So I think that's one of the areas where we have to look at different models, whether, I've started doing robotic surgery, which I'm very excited about, but again, this is something that only very few centers have access to because of, thankfully, because of donors most of the time. And so ways that we can support this kind of care through our universal healthcare system, but that's one thing, I see in the near future where we could potentially have remote surgery to smaller sites, or improve teaching of surgical providers in some of these regions because of those abilities of new technologies. So I think it's harnessing those new technologies and advocating for those and finding ways where we can support those financially, which overall could actually improve, stays in hospital and decrease costs. But because of various funding models and the way that we're siloed in the hospitals, those aren't necessarily recognized nationally or provincially. And so I think we have to start looking at things broader for what's best for patients in the healthcare system as well.
I wanted to ask another, just a question, just because there's been a lot of talk about access and supply. Could you just talk through, like, what does it take to specialize in women's reproductive health? Like, what does that journey look like for someone that does want to provide care? I think it is just helpful to understand, like, how do we start to build that supply? Like, there's the innovative pieces in terms of the technology and those parts, but I'm just curious, what does it actually take to increase that supply? Like, what's the journey? What does it look like?
Maybe I can start. Yeah. Speaking as a specialist, as a subspecialist, I think specialty care, is important for sure, and so people like Dr. Kroft, who have deep expertise in surgical treatment of some of these really complex conditions, is crucial. However, I do think, I think there is a role for the whole health system to have greater knowledge of women's health and the health of gender diverse people. And so I do think we're at a point in health education, medical education, perhaps nursing and other health disciplines education, where we sort of need to turn our traditional learning on its head and approach everything from the lens of sex and gender, so that we're trained right from the get-go to understand and appreciate those differences. Because the truth is, I think it is our primary care and allied health colleagues who will encounter a lot of these conditions initially. And I think we have to equip the whole health system to be able to at least start a preliminary kind of treatment and assessment for things like menopause, potentially for pelvic pain. I'm thinking of pelvic physiotherapy, as we were chatting about at lunch. I think that all of those elements are necessary throughout the system. And there is investment education-wise, nationally and provincially, to increase the group of clinicians who are familiar with this. At my hospital, Women's College Hospital, we've just opened a primary care menopause clinic. So it's a different kind of model of care where we have nurse practitioners who do that preliminary assessment and start treatment, and they also direct our patients towards self-management. So there are a lot of things that an individual may need to do to optimize their health, perhaps before they reach a specialist like myself or my colleagues here. So I think the idea that our whole educational system change to reflect the reality of what is needed for women and gender diverse people within our health system is crucial.
Yeah, thank you. Anyone else to add on to that in terms of how do we increase the supply?
I mean, I think it's a challenge because the training is so long and rigorous, and there's only so much funding for training. And I know we've all heard about challenges in terms of increasing physician supply and allied health supply. So I think it's great that there's a number of initiatives that are started, more medical schools within the city, and expansion. And I agree. I think it's teaching students from early on and opening their awareness of that. In no matter what specialty you're in, you're going to have women as patients and pregnant women as patients, and you have to deal with women's health in any specialty. And so I think it's incorporating that early on in training, so that even if it's not a gynecologist that the patient's seeing, that their physicians, are well versed in the nuances and the expertise that's needed to treat women and gender diverse individuals, and so that they feel safe in their care and also heard and validated. So I think it's a little off topic, but when I see a lot of patients with these kind of chronic conditions, as we've talked about, endometriosis, fibroids, and they see me, and I have students with me a lot and residents, and almost every new patient cries in my office, and it's kind of good and bad tears, but I see tears almost every new patient because it's the first time that they feel heard and validated, that they've had such a long journey. Endometriosis takes over 5.4 years on average to come with a diagnosis, and so I think that when they finally see somebody that validates their symptoms, recognizes that, and offers treatment, they're so happy, but it's also such a release of emotion. And I think that we really need to improve that I should not be the 10th specialist that they come and see before these symptoms are recognized. And as Cindy said, this should be screened for. It shouldn't be down at the 10th specialist that they see, that they get the attention they need. So I think it's really about putting that emphasis within education in all aspects of healthcare, not just obstetrics and gynecology and primary care.
Yeah, and we were talking over lunch about our children, and I even just think about how can you even have that education happen earlier for as part of learning and curriculum, right? So that you can figure out when you have some of those symptoms. So
in BC they actually have an endometriosis program for 13-year-olds, for grade 8 students, as a project that they were working on. So I totally agree. My kids are all well versed in endometriosis, but many others are not.
We need to spread that, right? Okay, there's a question that came from the audience. So with the creep of privatization of healthcare in Canada, do you see the government taking steps to ensure accessible healthcare for women without relying just on employers? I'll open it up to whoever wants to respond.
I'll give it a go.
Go for it.
The word creep sort of threw me off a little bit. I think I'm excited about femtech. Let me start with that. So, and maybe Julie will have something to say as well. I mean, there's all this this new access to virtual care. It's a whole new industry. I was reading it's like $1 billion industry now in Canada, which I think is, or maybe more, which I think is very exciting. And there are all these devices and technology that can help support. I think it's like female technology, femtech, right? So that can support different kinds of issues that arise in women's health. I met not too long ago a young female engineer, a biomedical engineer who's developing a device to help with menstrual problems, menstrual pain, pelvic pain, and things like that. So it's very exciting. And I think that femtech may be an important factor in perhaps expanding or extending access. In the case of Maven, I guess it's really that wraparound care that we strive for in the public system, but I just don't think we can reasonably achieve with the resources that we have at present. So I think that's one thought.
Yeah, I agree. I think that at the base we have to preserve our universal healthcare system, especially when sorry, Julie, look to the United States. So that
no, I was going to say, as the only non-Canadian up here, I'm actually I'm very hopeful about the future of funding and innovation in healthcare in Canada. So,
but I think that we just can't support everything we need to, which is demonstrated by the difficulty with accessing care, especially surgical care, that patients really need. So I think that we do have to potentially look to other models of care and creative ways that we can improve access to patients in Canada without compromising the universal publicly funded system. Is obviously a core value and something that I definitely believe in as well.
Yeah, go for it.
I was going to say, I'm, as I said, the only non-Canadian up here, but
But I'm really inspired by the way that we work with our Canadian clients, which differs a little bit from how we work with our US clients. And, I think all of the initiatives that we were talking about before, when we were talking about momentum and progress, like many of those come from the national healthcare system here. And the fact that, the employers that we work with in Canada, they don't have to worry about the costs associated with some of these treatments in the way that that exists in the US. And so it's really about, we are providing that bear hug around a system of care that is very robust already. And I think will continue to be more robust over time because there is momentum and excitement and funding for that within the government. So I'm very optimistic.
I just wanted to build on something, Dr. Maxwell, that you said around femtech, because I was at the femtech conference in November, and you could even hear the buzz at the conference in terms of women that are leading the way in terms of technology and even diagnostic tools. And I'd love to see how we can embrace and bring more of those into practice so that diagnosis can happen faster. If we were to be sitting here in 5 years from now, I'd love to hear from each of you, what would you want to look different? We've talked about a lot of the momentum. We've talked about what needs to change. But in 5 years from now, how do you want to see the conversation change? What does that look like for each of you? Let's start with you.
Sure, I could start. Maybe even earlier than 5 years from now. In my field, in obstetrics and gynecology in Canada, we don't have a national monitoring system for childbirth. So, near misses or people who die in childbirth. So that's what we call maternal mortality. And most high income and low income countries in the world have a system for this reporting. So this is an urgent need in Canada. Our National Society of Obstetricians and Gynecologists with national and provincial partners are working on this. So hopefully within 5 years we will have a national reporting system for these tragic events, because if you don't measure it, you can't fix it. You have to track each and every one of these events and then analyze and figure out what the trends are in order to propose solutions. I would like to propose that maybe we would have a national reporting system for, a sort of a dashboard to keep track of endometriosis and other gynecologic issues that affect women and gender diverse people. Again, if we're not measuring it in that way, it's very hard to report, it's very hard to influence change. We have wait times for most surgical type procedures. So if you need heart surgery or knee replacement, depending on where you are in the country, you can find out pretty quickly what the wait time for that type of operation would be. But I'm not aware of that kind of metric being available for gynecologic issues, to the best of my knowledge, and maybe others are more familiar. But I think that if we have provincial and national dashboards that focus on the issues that are really important to women's health, I think that could help drive change as well.
Yeah, I love that.
Yeah, I would say, similar in my field that endometriosis, fibroid surgery, those are classified as, primary level surgical cases in the province. So there's other cases that are recognized as tertiary, quaternary, meaning that they're more subspecialized, more complex and difficult to take care of. And we do very complex care at our institution. We have referrals from all over the province and even from other provinces that we get referred into our center. Yet they're still classified as primary cases. And so because of that classification, our funding is, we're funded in the same way. And institutions don't necessarily want to do a lot of high volume surgery for these complex cases because they cost a lot of money and the government's not remunerating the hospitals and the institutions for these complex cases. And so then it's a detriment to our patients, to our surgeons. And so I would really like to see recognition for the type of complex care that is provided. From a ministry level, I would like to see surgeons remunerated for what they're doing. We know that Gynecologic surgeons are remunerated less for sort of comparable cases to our male colleagues, and as somebody married to a urologist, I can tell you that's true firsthand. And then that deters people from doing gynecology. Our specialty of obstetrics and gynecology, at least within the province, is funded as one. So all of the money historically went towards obstetrics because people didn't necessarily want to do call overnight, and it was harder to get obstetricians to do calls. So the funding really went that way. So it's ended up with a lack of specialists providing gynecologic care, and that's why the wait times are growing. So I think, as Dr. Maxwell says, recognizing wait times for our cases and having wait time benchmarks, just like orthopedic surgery and heart surgery and cancer surgery has. We need to have those benchmarks for women's health procedures. We need to have better remuneration for our surgeons and better recognition and funding by the ministry. And I really think that will help in access, which obviously we've all talked about as being the biggest issue. And and then finally the technology. As I said, I've gotten into robotic surgery, other minimally invasive technologies that are so much better for our patients. And how do we get access to those newer technologies for women's healthcare is also really important to emphasize.
I'll just quickly add, I am really excited about where medical technology is going and its role in some of these things as well. Maven recently announced and launched a partnership with Oura Ring. There's probably a bunch of Oura Rings in the room right now. And it's just the beginning. But what we have seen from some of that data and that integration with our system is really remarkable, where we often have people come to us and say, we've been trying to get pregnant for a year, I don't know what's happening, and it turns out they just have an irregular cycle, and they're not doing things at the right time of the month or whatever it may be. And the patients who come to us now with the integration, their ring and the algorithms behind it that Maven and Oura have developed together are telling them that they have an irregular cycle and when they are ovulating, and they are coming to us essentially with the diagnosis in hand, right? And there's so much potential in that. And there's a long way to go for some of these technologies to be able to detect something like endometriosis or other things that are a little bit more complex or difficult to detect just with biomarkers. But there's a lot of possibility there, I think, to take out many of those 10 specialists before someone gets to you, that I'm really excited to see where that goes.
Yep, that's super exciting. Thank you for sharing that. There was a specific question that came in for you. The question is if you can talk about improvement in outcomes users have seen after using Maven. Like, for example, reduction in wait times. I know we talked, like some of it was in the video, but if you have any more stories to share or any data points.
Yeah, and I don't know if the question is more specifically about access or about
more clinical improvement in outcomes after using Maven.
Yeah, yes. So we have programs across the women's health spectrum. So Maven started as a wraparound product for maternity care, expanded into family building, fertility, and now we also have programs for menopause and for parenting and pediatrics. And, I think the easiest one to talk about, frankly, is menopause. We have 97% of users joining Maven who have a symptom that qualifies as severe on the MRS scale, which is a clinically validated tool. And of those people, we see 75% who are reducing their symptoms meaningfully within the first 3 months of the program. Some of that is through HRT prescriptions. Some of it is also for folks who may or may not be familiar with all the symptoms measured as part of menopause. Some are physical, some are mental. And so sometimes it's just a matter of getting someone quick access to a mental health provider. But I think that is one of the more stark numbers, is just to see
the symptom reduction that comes from that combination of physical and mental symptom addressing on the platform. And that's just so much quicker and so much more dramatic than people are able to achieve. Often they are coming to us because they've, seen 3 different OBs who are not trained in, treating the menopausal population, and they just haven't felt heard. Their symptoms haven't been addressed, and it can be really stark and really amazing to see.
Thank you. We just have 3 minutes left. I'm going to ask this quick question. So given the federal government has just launched a consultation on a men's health framework, do you have a sense of a timeline for women and gender diverse people? If you have any insights on that. I know there was a bill that was just talked about a couple of weeks ago, maybe it was last week, around a national women's health framework. I don't know if any of you are close to that and want to speak about it.
I think the timelines are always extended because change takes time, and so the types of initiatives that have been launched will focus somewhat on access to care and training new providers, but a lot of it will be on education and capacity building within the community. And so that, the life cycle of that type of work does take a number of years before it really filters down through to patients and families. I think that the investments that are being made are notable because they do focus on women's health, so that's a positive. Historically, Canada underinvests, particularly when it comes to women's health research. We know that there is an underinvestment in our country compared to other similar countries, that have a similar income nationally. So I think that these are all positive changes. I do think that with the entry of more women into medicine, health careers, and research, I think the representation also matters. I think we see that in obstetrics and gynecology. I think also femtech is quite has quite a female representation, but I think that is also important to drive change in the system. But that continues to take time. I think in some of the surgical areas in healthcare. And certainly, on the policy side, we continue to need more representation of women in those areas.
Thank you. So we're just under a minute. I just want to say thank you to the panel. It was really great to hear the insights, some of the momentum that's happening. Still a long way to go in terms of the challenges that need to be addressed, but just focusing on how do we support with access, how do we think about education. Really great to hear about Maven, and I love the concept of the bear hug around the system. And thank you to the Economic Club of Canada for providing this space, this forum, to be able to talk about this important issue, and we need to keep the conversation going. I think this is, the third of 4 series, but we need to keep talking about it. There's so much to do. So just thank you to the panel for being able to share your perspectives, and for everyone that's here in the room. And we just need to continue to move the conversation forward. Thank you.
Thanks so much.
Thank you.
Thank you.
So a big thank you to Zahra, Dr. Jamie, Dr. Cindy, and Julie for sharing all of their expertise today. We know we have so much more work to do in the world of endometriosis and the research and access to care. And I hope that everybody who does still suffer with it can find a solution soon, because 25 years of a long disease is really not a lot of fun. So on behalf of everyone at the Economic Club, a big thank you again to Manulife for being our partner in our Women's Health series. Thank you to Femtech Canada and the Sheridan Centre Toronto for being our event partners for today. And please mark your calendar for our 4th and final Women's Health event, which will be on May the 5th, A Lifetime of Care, Rethinking Chronic Illness in Women's Health. Registration information can be found on our website. Again, thank you for coming today, and we'll see you next time.